Well, welcome to Grand Rounds. We're going to go ahead and get started so that we can finish on time and go back to clinics on time. Before I introduce the speaker, I have a couple of things to tell you. First of all, as you know, this department has 3 residency programs. We have internal medicine residency program here at the DMC. We have another one at Crittenton, and we have a Med-Peds program here at the DMC. And this is the time when we get notification about the accreditation status, and all 3 programs are fully accredited without any limitations, without any concerns. So I want to congratulate the 3 program directors. I see one of them here, Dr. Weinberger. Let's give him a hand. Thank you for your efforts. The other thing I want to mention is that trainees in this department carry a lot of the clinical and academic weight, and they support the faculty in more ways than I can enumerate. And I decided that it's about time we start recognizing them for their efforts. And starting today, I'm going to be recognizing people who go above and beyond, and we have a couple today. So first of all, this is your CME information. Those of you who need or want their CME credits, this is the number to call, and this is the code. And it works until midnight, so don't forget to do it before midnight. Okay, we have two trainees who have been recognized by, by their program directors. Dr. Aaron Price proposed Dr. Patel for an Academic Achievement Award, and he will be getting this certificate. And the reason he was recognized is one of only 25 GI fellows nationwide who were selected to attend the North American Conference of GI Fellows in March 2016 in Florida. This is a prestigious conference. Only very few people get selected, and we have one of them. So congratulations, Dr. Patel. The second one is actually in the audience, Rick Blumendale. I don't know, is there anyone who doesn't know Rick? Is there anyone who hasn't contacted Rick with asking for something? So you all know that Rick holds several leadership positions, both in the department and at DMC. He leads the resident council. He updates our IT. He's our IT consultant, takes care of our website. He actually posted my YouTube video on the website. It's time to update that. He's going to be the chief resident at DRH next year. So it was difficult to decide which category we're going to recognize him in, whether it's clinical excellence, whether it's citizenship, whether it's academic achievement, probably all. But Jared selected clinical excellence, so congratulations, Rick. We appreciate all that you do. So at this time, I'm going to make a very brief introduction of Dr. Badr. I don't think there's anyone here who doesn't know Dr. Badr, who has not worked with him. And I'm always a little nervous because his presentations are so exciting that he will overshadow anything I say. So just briefly, Dr. Badr is a graduate of Damascus University, came to the US to do his internal medicine residency program in Chicago at Cook County. Following that, he was heavily recruited by a number of fellowship programs, and he did go to University of Wisconsin in Madison, where he stayed on the faculty until we were able to attract him here in 1996. And he came with his grants and with a dual appointment both at the VA and at Wayne State University. And very quickly, he became the chief of the Division of Pulmonary Critical Care and Sleep Medicine here at Wayne State University. He built one of the strongest sleep programs in the nation that continues to be recognized and accredited. He's a professor of medicine and physiology here at Wayne State. He is your typical triple threat in clinical excellence, teaching, and research. He's fully funded. He's had funding both from NIH and the VA medical grants pathways. And he has mentored probably all people who practice pulmonary critical care in the Detroit area, probably all of them. And we thank you for your willingness to share your knowledge with us today.
Thank you. Thank you. Appreciate it. So I'm going to talk about two things. One, talk about sleep in general as a broad concept, because I think one of the changes in the past 20 years is moving away from the idea of sleep disorder breathing as just a silo. So I'm going to talk about a concept called sleep deficiency and what it actually means. And I'm going to talk about some recent recommendations from professional societies. Then I'm going to switch a little bit to what an internist or a primary care physician needs to factor in as they assess these patients and when we need to think about it, and then just outline very briefly a diagnostic and management approach. So this is a bit of an eclectic talk. So I always get this question, what does sleep do? Well, nobody really knows what the function of sleep is. However, we know from at least animal investigation and human observations, if you don't sleep, you die. That's established. But how we get there, we don't know. So for those who practice sleep medicine, Alan Rechtschaffen is the kind of the father of the field or the grumpy uncle of the field, depending on how you look at it. And this is one of his lines. And he said, if sleep does not serve an absolutely vital function, then it is the biggest mistake the evolutionary process ever made. And actually, we know that it serves a vital function, but we do not know what this vital function is. Now, there are recent hints that sleep does something, which is the closest analogy came from one editorial. It's the garbage truck of the brain. So if you look at this slide, which is showing you all the metabolic waste, draining the metabolic waste from the brain is actually a function of sleep. And this is a cerebral spinal fluid influx in a murine model. And on the left, you see the red. That is the influx, or actually it is the outflux, in a sleeping brain. And to the right is the awake brain. So the brain being drained. This is a good way of looking at brain drain. It's draining the metabolic waste. Now, why is this relevant? Well, accumulating metabolic waste. Neurons produce beta amyloid. That is actually, with the structural changes, causes local toxicity. Remember the word amyloid, deposits in the brain. Sleep deprivation will make you accumulate amyloid. So chronic sleep restriction promotes amyloid plaque formation. So now this is a very exciting area, people wondering, is there a relationship between sleep deprivation and Alzheimer's disease? Now, it will be oversimplistic to think that it's a one-way or a single factor, but it's clearly an area that deserves further investigation. So now, the term that has been introduced recently is sleep deficiency. So we talk about not insufficient sleep. That's one model of sleep deficiency. Trainees, medical trainees, many physicians, many professionals, or those who have insomnia. Now we talk about poor sleep quality, fragmented sleep. That's sleep apnea, periodic leg movements during sleep, circadian misalignment, that's shift work, jet lag, or any circadian rhythm disorder. And finally, we're left with a small thing of primary sleep disorder, such as narcolepsy. So 50 to 70 million Americans suffer from sleep deficiency. That's a huge number. That's about 1/4 of the population. Now, our problem with this began with Thomas Edison. Thomas Edison said sleep is a criminal waste of time. Okay? All of our current culture, the Wall Street culture, the physician culture, burning the midnight oil, staying up all night, actually came from him. And that was the beginning of the dark ages of sleep health. You can put the lights back on. Huh? So clearly, Thomas Edison was wrong. Sleep curtailment is not a virtue. Okay? What sleep curtailment will make up for any one of us will be grumpy, accident-prone, and obese. Okay? So, and that's actually, there's enough literature, I'm going to talk about some of it, to say it will actually affect emotional state, accuracy of job performance, and weight management. So, this is the issue. Adults sleeping less than 6 hours from 1985 till 2004. Clearly a substantial increase. 50 to 70 million Americans. This is 2006. The number is probably higher today. So 1 out of 4 people in this auditorium have sleep deficiency, have some form of sleep disorder. 1/3 of adult Americans have actually insufficient sleep. 70% of high school adolescents. Look at this number. 70% of high school adolescents. Now, on top of it, high school adolescents are phase delayed, which meaning left to their own devices, they want to go to sleep at 2 in the morning and sleep till 10. What time does high school start? Very early, okay? And they're taking math first hour. Can you imagine? They're like zombies at that time. They have to think about math, and we wonder why Korean kids are overtaking our kids in math performance. Okay? That's actually there is some movement afoot around the country to start changing school start time. This has huge economic implications. It is not a fast thing. There are a few countries, actually, it started in Israel with Peretz Levi, that they're moving school start time a little later, and I think there may be others. Shift work, 1/5 of the population. That's also a huge number. Shift work is not healthy. Sleep health is now a national priority for the Healthy People 2020. So this is starting to move into the forefront of our thinking. So one simple way to think about if you don't get enough sleep, many of us sometimes feel a little achy, feel a little tired. Why? Well, this is one example to show you. These are two graphs showing you IL-6, just one random cytokine, okay, before and after partial sleep restriction. It's very clear that sleep deprivation or sleep curtailment is pro-inflammatory. Your pain sensitivity changes, it's pro-inflammatory. Another one happens when we don't get enough sleep, on a post-call night. I've been up all night. By a show of hand, anybody in the morning at 6 in the morning say, boy, I'm really craving some broccoli? Anybody? Anybody says, I'm really craving a muffin? Okay, the rest I don't want to admit it, but I bet all of you, myself included, when you're actually sleep deprived, you crave high carbohydrate fatty diet. And that's actually been shown. It's actually your appetite is higher. This is from the University of Chicago looking at leptin level with sleep. Leptin is down and ghrelin is up with sleep deprivation. So your satiety hormone is down and your hunger hormone is up. This is actually very consistent. The original studies were only 6 hours. 6 hours is a normal thing for a whole lot of people. Okay? Also, by a show of hand, how many here sleep more than 7 hours? 7 or more? How many sleep less than 5? How many between 5 and 6? Okay? So there's very few people, remember this number 7. There are very few people, and some people didn't raise their hands. They're probably sleeping right now. BMI. And if you actually look at the BMI, you can see the lowest BMI is around an age around 7 to 8 hours of sleep. So clearly there is a relationship between total sleep time and daytime function. And the ultimate is mortality. And this is the cancer prevention study. This was not done to look at sleep in any way. But then when they looked at it, again, you see that there is a nadir of mortality around 7 to 8. There has been a debate in the field about the more than 9 hours. And some people say it's in and of itself a problem. Others believe that it's a marker of time in bed. If you have a chronic condition, you're more likely to spend time in bed. But that doesn't necessarily mean you're actually sleeping 9 hours. There are no data on this area. Sleepiness and sleep deprivation and its consequences. Well, drowsy driving. 250,000 drivers fall asleep every day. A crash every 25 seconds. So there has been 10, 15 crashes since I started talking. Injury every minute. Debilitating injury every 10 minutes. A fatality every 70 minutes. So from the time I started talking to the time you get back to your office, that's 70 minutes. There will be one person in the United States who's dead from a car accident because of sleepiness. These are actually sobering numbers that we all need to remember. Without knowing all the details, most of the major, large, catastrophic industrial accidents have sleepiness as part of it. The Challenger, Exxon Valdez, 3 Mile Island, Chernobyl, all of these. Every time it was traced, that was actually a factor. People who are my age will remember exactly where they were sitting or standing on what they were doing when the Challenger blew up. I was seeing a patient on the nephrology floor, and as I was ausculting, I was listening, and I saw it on TV. Many of us do remember. But look what the Presidential Commission on the Accident Report said. The willingness of NASA employees to work excessive hours, while admirable, raises serious questions when it jeopardizes job performance, particularly when critical management decisions are at stake. And there were management decisions related to the O-ring that was probably related to sleep deprivation. So one of the things we kept on hearing for years is, okay, how many hours of sleep do we need to get? And I always get that question. And I've always referred them to my grandmothers, 8 hours. Okay? That's the number I was raised with. But actually, if you look at the literature, it was very difficult to find it. So as part of a CDC project that the American Academy of Sleep Medicine and the Sleep Research Society have was, well, let's come up with some evidence-based standards. Let's look what the literature said. So this is the conference panel. There were like 15 of us. And we did a comprehensive literature search, looked at the best evidence, looked high-level evidence, all of it. And we categorized the evidence, and we did modified RAND. When first voting was by email, we had to review all of these articles. And then they were scored by median. And then we had a face-to-face meeting in Chicago. So they wanted to make sure that that our ADD doesn't get the best of us. So they locked us up in a room for 2 days. It was in Chicago in the middle of winter near the airport. So there was no place to go except to work. And we went through these different categories: human performance, mortality, metabolic health, cardiovascular health, immunologic health, mental health, pain, cancer, and general health. And there were about 500 or so articles that were part of that analysis and repetitive voting until we get to a narrow band. The only one that fell off was cancer, fortunately, because there wasn't enough evidence. Most of the evidence were in breast cancer, and it was fairly limited, not enough to make a statement. The summary of this is that adults should sleep 7 or more hours per night on a regular basis. That's actually the bottom line. And you look at the literature, it was very, very consistent. 7 hours was a threshold. So one of the things that I actually started doing, I started getting 7 hours or more. And I found that actually that it was good for my ADD. It was actually very useful. It will allow one to focus a little bit more. So the recommendations: sleeping less than 7 hours is associated with adverse outcomes: weight gain, obesity, diabetes, hypertension, heart disease, stroke, depression, increased risk of death. Okay? Sleeping less than 7 hours, impaired immune function, increased pain, impaired performance, increased errors, and greater risk of accidents. Pretty much just about anything bad that you can imagine. Now, this is the difficult one, and this is where professional societies aren't necessarily all aligned. Sleeping more than 9 hours may be appropriate for young adults. Clearly, 19-year-olds need 9 hours of sleep. 17-year-olds need 9 hours of sleep. Athletes, college athletes, high school athletes need 9 hours of sleep. However, individuals are also recovering from sleep debt. But we don't really know if an otherwise healthy adult sleeps 9.5 hours to feel okay, has a problem or not. What I tell everyone, if that's what you need to feel rested, that's what you need to feel rested, because we don't really have any evidence that in and of itself is bad for you. People concerned, they need to actually talk to their doctor. And fortunately, most physicians are not trained to handle sleep issues. For the most part, we get sleeping pills or sleep study. These are the two things that we see. So hopefully, we're educating the public, encouraging individuals, discussing economic and social benefits, and promoting research. What I actually do many times, I can't do it anymore, we don't have a prescription pad. I actually used to write it on a prescription pad. more than 7 hours of sleep times 2 weeks, and come back and tell me. Let's do an experiment. I haven't had anyone actually go back. If they actually do it, they'll know exactly the benefit of it. So sleep is important, quality and quantity. Sleep deprivation has adverse outcome, and treatment is effective. We have things we can do for patients who have any sleep deficiency, any sleep dysfunction. So I'm going to move now, switch to the respiratory system. Here it is, I've been promoting sleep as this cuddly, the balm of souls, the resting period. How about, is it truly cuddly when it comes to the respiratory system? And this is one anomaly that is hard to explain. Or is it actually a grizzly? Is it good or is it bad? What does it do to the respiratory system? Is it a rest period? Well, there is evidence, enough evidence to say for the respiratory system, it's probably not. So here it is an actual image looking at the cross-sectional area of the retropalatal airway, just representative of the upper airway. Just look at the inspiratory part, and it's outlined. Usually it doesn't come outlined, we outlined it. And this is the lumen. This is the lumen during sleep. The airway is narrowing. The airway in each and every one of you will narrow during sleep. Actually, you can tell that the person next to you fell asleep because you can hear their breathing, because the airway is narrower. And now you have more turbulence. And when there's turbulence, you hear it. This is one of the first studies that James and I did here in Michigan, published 1998, looked at the cross-sectional area of the upper airway, retropalatal, in wake, non-REM, tonic REM, and phasic REM. And clearly, the cross-sectional area decreased. This is a universal finding. These are not patients with sleep apnea. These are healthy young adults. Simply being asleep, the airway is narrower. Now, we know about snoring. That's the one that we hear. When the airway narrows even further, now you have more turbulence, and you start hearing the fluttering of the soft palate, affectionately known as snoring. Now, what does this mean physiologically? And I promise this is the only physiologic slide that I will inflict on the group. So this is a polygraph, a physiologic polygraph, not typical sleep study, having the diaphragmatic EMG, the scalene EMG, the abdominal muscle, end-tidal CO2, esophageal pressure, and flow. So one way to look at it is look what's happening to the respiratory muscle activity. It's actually increasing. Look what happened to the abdominal muscle activity. There is abdominal muscle on expiration. Our abdominal muscles are silent when we are awake. They actually, when we move, they're postural muscles. They're used for forced expiration, to blow a birthday candle, but they're not usually used under resting condition. And this is the end-tidal CO2. The line here where it was during wakefulness, look that there is actually hypercarbia. Look how much negative pressure being generated. So during sleep, this is a young, healthy individual who just happened to snore, is generating a lot of effort, but retaining CO2. This is a normal physiologic response. There is extra work here. This is not a resting system. Imagine on top of it now we have obesity, narrow airway, and you can imagine how all the adverse effects will happen. So we now talk about a continuum of collapsibility, from a normal patent upper airway to a narrowed airway of a snoring individual to a closed airway, a patient with obstructive sleep apnea. And it's all a continuum. What are the symptoms? Well, the most common symptom is habitual snoring. However, I caution you, not every snorer has sleep apnea. The same way, not every patient who is febrile has severe sepsis. Okay? There are other reasons why we need to think of. Excessive daytime sleepiness, which we measure, witnessed apneas, multiple nocturnal arousals, morning headache, and reflux. So this is what a typical polysomnographic segment will look for an obstructive apnea. These are all the EEG and the EOG. This is the flow. This is the sum of the effort channels. And there is where the arrow is showing us that there is no flow, but there is persistent effort. No flow with persistent effort. That's a typical obstructive sleep apnea. And when we compress the whole night, every event that we're seeing, will give you a vertical line in saturation. This is an example of it. When they're kind of crunched together, they will look like a bunch of sawtooth waves. And then when we applied nasal CPAP, you can see that this has resolved. So how common is the disease? That's one of the issues that we always think about. So this is the Wisconsin Sleep Cohort Study 1993, which was the very first community-based epidemiologic study. This did not look at clinic patients, sleep lab patients, looked at employed individuals from Dane County, Wisconsin. And we had at that time about 600 patients, and this is the graph summarizing the results. Among men, 24% of the men met the minimum diagnostic criteria, which is 5 abnormal respiratory events per hour of sleep. That's kind of an arbitrary threshold that was predetermined. 24%, 1 out of 4. Among snorers, it was about 1 out of 3. In women, it was about 9%. And among snoring women was 1 out of 5. Remember what I mentioned earlier. Not every snorer has sleep apnea. This is kind of the numbers for these individuals. These are not patients. These are community dwellers employed from the state of Wisconsin. There are a bunch of problems with this. The socioeconomics, these are all employed, and the racial and ethnic composition of Dane County, Wisconsin. These are 2 limitations for generalizability. Another one from Hershey, Pennsylvania, which is even a larger number. These are the obstructive apnea, and you can see depending on the definition, things will vary. I'm going to go back to this one. When this operational definition was combined with a symptom, because we can't say 1 out of 4 have a disease. That's really a horrible disease to have if it's 1/4 of the population. So when combining the presence of apnea-hypopnea index more than 5 and daytime sleepiness or symptoms, that became 2% and 4%. So at that time, 1993, 2% of the women, 4% of the men met the minimum diagnostic criteria that we use in a clinic. The data from Hershey was very similar, somewhere between 2 to 4%. Is there a problem with the data for now? What has changed from 1993 till today? Obesity. Exactly. So we'll talk about obesity. So this is the obesity map in 1993. 15 to 19%. This is, at that time I was between Wisconsin and Chicago. I was in Wisconsin, and this is Michigan. Okay? 15 to 19% of the population had BMI over 30. We'll move to when the Hershey study in 1999 was published. And now Michigan is more than 20%. Wisconsin is still in the 15 to 19%. This is 2010. We are more than 30%. Okay? More than 30% of the population have a BMI over 30 in the state of Michigan. 25% or so in the state of Wisconsin. You can see the West leads the nation in at least the lowest BMI. And the funny thing is that 1995, Time magazine complained about girth of a nation. Yeltsin was still alive, was still president of Russia at the time. And I don't know what their heading would be today. So what does actually weight loss and weight change do to sleep disorder breathing? Well, this is from the Wisconsin Sleep Cohort Study. They followed these individuals over several years. And what they found that if you increase your weight by 10% or more, you add 5 events per hour of sleep. So let me put this in some real numbers. Somebody's weight is 150 pounds. 4 years later, that person is 166 pounds. That's 4 holiday seasons, 5 holiday seasons. Very easy to achieve. It's not a difficult thing. That person would go from no sleep disorder breathing to meeting the minimum criteria for disease, just by adding 10% of body weight. Now, if you look in reverse, unfortunately, the story is less compelling. Yes, there is a decrease, but that decrease is not the same. The slope of the decrease is less. Because once the disease is established, there are probably some permanent changes that we don't really know. So the claim that we hear out there from bariatric surgeons that I will cure your sleep apnea is an incorrect statement. And I correct all my colleagues in bariatric when they say that, because I cannot promise anyone that I can actually cure their sleep apnea no matter what we do. Perhaps Drake. The Sleep Heart Health Study had also another large study, 6,000 participants across the country. The beauty of this study, it has diverse geographic, racial, and ethnic distribution. And clearly, it looked like the men were a lot more susceptible to changes in weight. And that might have something to do with the central obesity. So Paul Papar, who is the leader of the Wisconsin Sleep Cohort Study, decided to redo the numbers. He said, well, let's factor in. Nobody's going to do another epidemiologic study of that magnitude. Let's figure out what happened actually if we change the numbers with the current obesity. So let me just look at his estimation of the disease. Let's look at this panel. And he estimated that between 1988 to 1944, it's expanded from the actual published paper, somewhere around 10% of the men met the minimum diagnostic criteria. Today, it's 14%. And that's, again, in the state of Wisconsin with its own composition. And in women, 3.8 to 5%. So as we speak now, 15% of the men, kind of the lowest level of tipping at a restaurant, 15% of the men have sleep disorder breathing, and 5% of the women. This is a much larger burden of disease than we thought of about 23 years ago. So other associations that are relevant to us in a clinical practice setting. Well, reflux is one of the most common symptoms that we deal with in primary care. And this is what happens when you have a reflux event, and you will find that there is an arousal. And what we found that many times reflux happens because of upper airway obstruction. You're obstructing your airway, you're generating more negative pressure, and eventually you break that barrier. And it's actually one of the symptoms I inquire from my patients as I'm seeing them the first time and as they're using CPAP. Did their reflux go away? And the vast majority of the patients that I see actually have reflux or are on anti-reflux medications. And what you will see, a lot of them actually, they produce arousals. 62% of these will produce arousal. So even if they're not related directly to an event, they fragment sleep. And this is what happened in one study. This is talk from Oklahoma. And obviously, this is before CPAP, and this is after CPAP. And obviously, you can see everything decrease. They clearly had the one outlier that makes the graph look much nicer and much more impressive. But even if you take it out and look only at these, every one of them came down. And this is actually an important question. So one thing to keep in mind as we actually ask about reflux. Another condition, which is a lot more common, is type 2 diabetes. Somewhere between 60 to 80% of patients with type 2 diabetes have sleep apnea. This is a huge number. This is one of the studies, one of the best studies from the University of Chicago. They looked at 60 patients with type 2 diabetes. They did a polysomnography on them, not a home study. They found OSA in 46. These are consecutive patients with type 2 diabetes. And the severity correlated with diabetes control. So you look here, no OSA. This is the hemoglobin A1C. And you can see as the disease increased in severity, hemoglobin A1C worsened. And there is some evidence that treatment will improve diuretic control. The problem is that this is not known. This is not known in a whole lot of, while many of the studies, this is a study in primary care looking back at the percentage of sleep apnea in a patient population. And these are all the studies that actually looked at it carefully, and you can see what the prevalence of sleep apnea among patients with type 2 diabetes. This study found less than 20. Why? Because people aren't thinking about it. People are not considering sleep apnea when they're treating their patients with type 2 diabetes. I always say this to ACOs and primary care panels and HMOs. You want to improve the hemoglobin A1C in your patient panel? Look for their sleep apnea and treat their sleep apnea. It will probably make that much easier. Kidney disease, that's another one of these associations. The study looked at 657 patients, 254 completed the study, and the numbers are very compelling. So if you have ESRD, somewhere around more than half of the patients will actually have sleep apnea. So it's a higher than a coin toss. It's like 50% of the patients will have sleep apnea. And you can start seeing it even when you have CKD. And you can start seeing it even at GFR. We can argue about this one, but once you get to CKD or ESRD, clearly it's much worse. And you can see almost a dose response curve. So that's something we need to factor in. Now, if you're considering kidney transplant, it's probably important to treat sleep disorder breathing. And it clearly correlated with a degree of desaturation. So how do we make the diagnosis? Well, clinical features, and this is one of the things patients with obese patients, type 2 diabetes, kidney dysfunction, reflux, uncontrolled hypertension, I'm going to talk about hypertension a little bit. All of these are patients we need to factor in. One of the problems is sleep is nowhere on the review of system in any clinic. I've looked at a bunch of pre-printed review of system. They have galactorrhea, they have enuresis, they have flashing lights, they have a whole bunch of nonsense, okay, that I rarely see. They don't have how many hours of sleep do you get? Are you tired during the day? What's your sleep quality? They have none of that. None of this. They don't have if you snore, nothing about sleep. 1/3 of our life is totally in the dark. We don't ask about it, like out of sight, out of mind. And that's actually one of the things that we need to start changing as we practice medicine. We need to start inquiring about these. Morphology. I love morphology because it's actually one of my entertainment when I'm waiting for a delayed flight is look at people and try to estimate their CPAP level. So this gentleman here, it's not very hard to figure out. He's retrognathic, and that means his upper airway is actually smaller. The bony structure is smaller, and hence the tongue is occupying a larger space. There is less room for air. So Jay Leno does not have sleep apnea, as at least I would like to guess. We stole something called the Malapati classification from anesthesiologists, and clearly this is a very closed airway. You can't really see anything. Chances are this patient or individual has sleep apnea. The caveat is you could have all of this being totally negative and you could still have sleep disorder breathing. Do not use the morphology to exclude the disease. And I've seen sleep apnea in people who are very thin, who you look in their upper airway looks perfectly fine. They have normal BMI. So don't use that as an exclusionary. One of the ones that are very useful is neck circumference. So gentlemen, by show of hands, who wears 17, shirt 17 or higher? Okay, so there are only 3 people who raised their hand. So one of you has sleep apnea. Okay, that is the statistics. One of you has sleep apnea. So this is 43 is size 17 or higher. 1/3 almost has sleep apnea. Now in women the numbers are different because the distribution of fat is different. Women have a smaller neck circumference for a given BMI. But again, you still have a fairly high distribution. Again, size 17 or higher, 1/3 have sleep apnea. Again, that's a business opportunity. Go to Macy or one of these department stores, stick referral cards for sleep lab and all the shirts 17 or higher. Consequences. Well, hypoxia, arrhythmia, ischemia, cognitive consequences, systemic hypertension, and cardiac disease and their mortality. Hypertension. Sleep apnea is now a cause of what is referred to as essential hypertension. Okay? We have to think of it that way, independent of BMI, independent of anything else. And this is also from the Wisconsin Sleep Cohort Study. And this is a longitudinal study. And look what we're finding. Look at the gray bar, adjusted odds ratio, almost 3. Adjusted for everything you can adjust to. These are community dwellers. The bottom line is clinically significant sleep disorder breathing, AHI above 15 as a threshold, doubles your risk of having hypertension. Okay? If you have a patient with hypertension who is difficult to control, has resistant hypertension, needing 3 medications or more, chances are that more than 70% they may have sleep apnea. These are the people who need to be studied. The ultimate, mortality. The skeptics have always been telling us, well, but if it's not killing, why are you worried about it? Well, now we have data that it is actually killing patients. This is also the Wisconsin sleep cohort study. They looked at the data now that they have 18 years of follow-up. And you look at the graphs. Pretty much simply when you look at AHI more than 30, they have a significant increase in mortality, a much less survival over an 18-year period. The Wisconsin sleep cohort study was almost 21,000 person year, severe sleep disorder breathing associated with a 3-fold increase in all-cause mortality. And that actually was higher when they excluded patients who use CPAP. Remember, this is an epidemiology, so they can't really control what patients are on. But when they took all the patients who are using CPAP, the odds ratio went up to 3.8. So clearly, it is associated with increased mortality. The other study, which is a larger study and equally powerful, is the sleep heart health study. And this was a shorter period of observation, but the finding is exactly the same. Over a 10-year period, there is a clear increase in mortality. The probability of survival was decreased in patients who have severe sleep disorder breathing. So let's talk a little bit about treatment. Well, the problem with this disease is that we stole the language of treatment from hypertension. Hypertension, we use blood pressure, millimeters of mercury. The method of measurement is exactly the same. Whether you are in Beijing or in Seattle or in Detroit, blood pressure is measured the same. The measurements are the same. The units are the same. It is standardized. Unfortunately, this is not the case with sleep apnea. You take one study in one sleep lab to another sleep lab, you get different numbers, different operational definitions, different sensors sometimes that make things vary a lot. But the bottom line is that we know that there is a threshold somewhere for treatment. We don't really know where to draw that line. And that's actually important. There is actually a recent document that Dr. Chowdhury led the development of the treatment of mild sleep disorder breathing that is published, trying to address some of these issues. So the analogy with systemic hypertension is limiting. There are reimbursement guidelines. We have different payers who pay at different levels. The bottom line is that the use of apnea-hypopnea index is probably not the optimal metric. It's probably not reflective of the actual physiologic insult, but that's the best we have. And at some point, probably we'll be moving towards something else. Another issue, which is body weight affects how you measure an event. So on this one, I'm showing you a supine. This is a non-obese individual. This is the FRC, which is your oxygen store. Your oxygen stores decreased. People who are obese have smaller lung volumes, which meaning if they go apneic, they will desaturate faster. They can't dive as well as others for the same reason. So the treatment of sleep apnea is, we have this device called nasal CPAP. And this is a picture of the very original nasal CPAP machine from the University of Sydney in Australia. This is courtesy of Sam Kuna in Philadelphia. And as you can see, this is an inverted vacuum cleaner. And everything was put together with duct tape and medical tape. At that time, they used to have customized nasal mask. I guess Mark Twain probably had sleep apnea. I see his picture here. And we know that this works. This treatment actually, every physiologic metric we look at, we see an improvement. For example, motor vehicle accidents decrease. Systemic hypertension. This is a forest plot. If you look at the diamond, it shows you where the net effect is. The vast majority of the studies show you an improvement. Now, for a cynic like me, I'm a physiologist. When I see a small decrease in blood pressure, I say, oh, what the heck is that? But from an epidemiologic standpoint, this small, consistent decrease is very powerful. It's translated into very significant clinical effect. Same thing in any way you measure the blood pressure, including mean airway pressure. Now, Another question that we all face, and you will probably face in your own practice, is how long should a patient use their machine? Well, I have reimbursement guidelines require 4 hours. Is 4 hours enough? I have patients who use it 4 hours and then take it off. They think it's like passing a test. Okay, I got my minimal. Well, Terry Weaver, she did this wonderful study. She looked at different metrics and said, how much improvement do we get in 4 hours? And do we need to do more? And just look at the triangles, and you can, this is the multiple sleep latency test, an objective test of sleepiness. And what you can see is that there is an improvement up until 5. It plateaus above 6. But if you look at another one, which is a sleep quality called FOSQ, it continues to improve till 7. So I tell my patients, and that's the important point, every time you sleep, you need to use your CPAP. Even when you nap, you need to use your PAP. And that's probably the most important message, is that the total sleep time. And she found that there are different thresholds depending on the condition. So the bottom line of this is that it has to be used consistently. So I'm going to end with an illustrative case that some of you might have seen. And I like to use this case because it highlights the relevance of this condition on a broader scale. This is a 45-year-old male who has EDS. He slept during a thunderous storm and during a meeting with his boss. Not a good idea. He fell asleep on speaking platforms, in cars, while dining out, at church, theater, and at a funeral. He fell asleep playing cards. He fell asleep signing documents and while eating. He became sleepy playing golf. I mean, it's a boring sport, I give you that, but okay. He could sleep standing up. People saw a deterioration in his mind and expression. Some of the comments from people surrounding him, ripe for a stroke. He was called the blunderer. He lost his job. And actually, this might have saved his life. Free from the strains of his challenging job, he dropped his weight from 340 pounds to 264 pounds. Still not svelte, but that's a significant improvement. His sleepiness vanished. His blood pressure fell. In the last years of his life, he was extremely effective as President William Howard Taft. President Taft was the first president who got stuck in the bathtub of the White House. They actually had to get a crane to pull him out, and they built a larger tub because of him. Okay? These are pictures of him actually asleep standing. And he was the governor of the Philippines, Secretary of War, President of the United States, lost the election, okay? And he became Chief Justice of the United States. Somebody took the time to plot his weight with his jobs. Okay? So you can see as he was the governor of the Philippines, his weight was increasing. I guess he liked the food there. And then when he was Secretary of War, his weight dropped. Okay? When he became president, his weight kept on increasing. Okay? And then when he lost the election, his weight dropped. And then soon after, he stabilized his weight and he became Chief Justice. He's actually one of the most brilliant legal minds in our history. And it's actually all happened after he lost the election. But notice the language: blood pressure, stroke, job performance. We're talking here in the 19th century. We're talking a long time ago. I mean, he was a president 1908 to 1913. So we're talking more than 100 years ago. People knew that. At that time, obviously, he never had a polysomnogram. Nobody knew what sleep apnea was. It wasn't even prior to the very first medical description, but he clearly had it. Now people are pulling documents related to Napoleon Bonaparte, and they're finding a very similar pattern of his performance, and including some of his military losses. So really, sleep apnea, when it deprives your brain of oxygen, it's really affecting your executive function. It's a lot of decisions we make may probably not be as good as we think they are. So as we suffer as a nation from increased obesity rates, we suffer from increased prevalence of this disease. We have to think of chronic medical conditions. For anyone who sees patients in a primary care setting, I really want you to remember this. Forget everything else. Hypertension, type 2 diabetes, chronic kidney disease, reflux. This is kind of our classic nightmare patients. Okay? Think of all of these as reasons to suspect the condition. And we really need to inquire about snoring, hypersomnia, quality of sleep, and at least one clinical intake as we evaluate patients. Now, issues for the future, unattended monitoring. It's coming at us basically like a tornado, and it's complicating life for taking care of patients. There may be, maybe what we call sleep apnea is not one disease. Maybe it's multiple pathways. And right now, to steal something from Dr. Chandra once said about good news and bad news, the good news is that we have CPAP. The bad news is that we have CPAP. That's all we have. We treat all patterns, but it is not exactly a personalized medicine. It's not precision medicine. There are reimbursement changes that are happening very fast. Unfortunately, I call this the bad apple syndrome. People in the private setting sometimes overdo things, and we all have to suffer for it. Adherence to therapy is a huge issue. Patients are lying to us, just let's accept it. And finally, maybe we're moving toward a chronic disease management model, that we can't think of it as a silo. We have to create partnerships and groups, all of us who are actually invested in the care of these patients. So perhaps actually it's moving to becoming a family disease. And this is a picture of a husband and wife who actually both have CPAP. And I guess after a while, they start looking like each other when they use the CPAP for a long time. So thank you for staying awake, and I'll be happy to answer any questions. Yes? Oh, sleep deficiency is the broader term that includes disorder plus behavioral. So if you're curtailing your sleep by design, you have a sleep deficiency. You don't have to have a sleep disease. So it's a broader term. And that's the one that's 1/4 of the population. Yes? Thank you.
All these apparatus that we use for the sleep disorder, it looks pretty complicated and cumbersome. Therefore, the adherence is a big problem. What are the areas of really make it simpler so that there will be better adherence?
Well, actually, this is a common scenario, which is people think of CPAP adherence as less than other diseases. The question is, the CPAP apparatus is a cumbersome contraption, which may actually affect adherence to treatment. But when, in a chronic disease, when they compared CPAP to antihypertensive medication, the use of supplemental oxygen for patients who need 24-hour oxygen, even adherence to dialysis, they found that all of these models, all of any chronic disease that we treat patients for, have somewhere between 50 to 70% adherence. So nothing that we've done so far has been able to change it for CPAP, even the different types of pressure. The only one was educational level and intervening early, because by the time I see a patient, it's been 2 months they've been on the CPAP. I think that's too late. So now one of the things we have is a web-based and a cloud-based monitoring, remote monitoring, where we know within a week that a patient isn't using the CPAP and we can intervene. But there's really nothing else as of now. There are some hypoglossal nerve stimulation for a subset. There are subsets of treatments, but they're not really focused yet. Yes? Well, masks now, there are like about 100 or so masks. So patients who have a problem with masks, they need to be seen again so we can give them a different interface. I mean, that's just the easiest way. There are people who like full face masks, some of those who like a nasal mask, some who like nasal prongs. The problem is sometimes payers, we give somebody a mask based on some guess, and they say, you have to wait till September to get another mask, which is kind of stupid, but these are the issues we deal with. Okay, thank you guys, appreciate it.